respected senior doctors and my colleagues and my junior doctors and my students, on behalf of JIP Academy, I want to greet each one of you. I think that you are aware of this program, which is nothing but JIP Academy. So, JIP Academy is intended to promote medical education among doctors. நான் ஒவ்வொரு வாரமும் ஒரு சில டாபிக்ஸை சூஸ் பண்ணி I want to explain in a very simple way to our junior doctors. To some extent, the non-medical specialty doctors also may be benefited with this program. So, இன்னைக்கு நம்ம பார்க்குற program, how to approach acute chest pain. So, it is one of the common emergencies we face every day. You do agree. So, what are the causes of, important causes of acute chest pain? So, please remember in such a way that 2 A's and 4 P's. Okay, what is 2 A's? One is acute coronary syndrome and aortic dissection. And 4 P's, pneumothorax, that is tension pneumothorax, and second pulmonary embolism, and third one pericarditis, fourth one pneumonia. So, if somebody is coming with chest pain, so they may throw some clues by which we can narrow down the differential diagnosis of chest pain. For example, if somebody is experiencing central chest pain, excruciating type, radiating to left arm, sometimes it may radiate up to jaw and going down up to the umbilicus, radiating back to the scapular region. So, it's all very typical of acute coronary syndrome. Okay. More diagnosis which deserves same quality of chest pain is nothing but aortic dissection. Aortic dissection patient also, they will experience severe central chest pain and that will radiate to back. So, how will you differentiate this, whether you are dealing with acute coronary syndrome or aortic dissection? Okay. What do you mean by aortic dissection? It is a tearing between that aortic wall between the intima and the media. So, when the tear occurs, there is a gap between the intima and the media in which blood flows inside. So, that is called aortic dissection. So, how will you differentiate? Generally, if it is an acute coronary syndrome, 60 to 70% of the patient, they may have some ECG signs. Okay. Acute coronary syndrome, it encompasses non-ST-MI and ST elevation MI. So, you have to find some form of ST elevation or sometimes ST depression or T wave inversion. So, this kind of ECG changes are suggestive of acute coronary syndrome. But aortic dissection, they may not have any florid ECG signs. So, somebody is presenting with central chest pain, you are not able to pick up any ECG finding, then probably you should be alerted to think of aortic dissection, which may be a very rare disease. And when you have aortic dissection, what happens? Because of involvement of aortic branches, you will have a pulse variation will be there. One side pulse may be felt and another side may not be felt. So, you have to palpate the pulse on both sides. That will give rise to clue for aortic dissection. Number 2. And what about pericarditis pain? Pericarditis pain also will be centralized pain, stabbing nature. And very peculiar nature of pericarditis pain is when they lean forward, the pain will come down. So, when they lean forward, what happens? The pressure over the pericardium is coming down. So, they will have some relief. So, somebody is having chest pain, you just ask them to lean forward. If there is any relief, then probably you can suspect pericarditis. Pericarditis also, depending upon the stages, they may have also ECG signs. So, they will have ST elevation like MI. But we used to say concave upward ST elevation they will have. That also you have to keep it in mind. And pneumothorax and pneumonia, the remaining 2. So, pneumothorax, very classical finding is decreased air entry on the one side. What I am trying to say, which pneumothorax that will cause acute chest pain, it's a tension pneumothorax. So, tension pneumothorax is air collection between the parietal and visceral pleura, which results in shifting of mediastinal structures to one side. So, it will push the heart to one side. So, what happened because of compression, your venous return, everything will be compromised. So, cardiac output would be low. So, they will develop hypotension as well. Okay. So, how will you diagnose tension pneumothorax? The most important clinical finding is when you auscultate, whichever side you develop pneumothorax, that side part of chest you won't hear any air entry. So, most of the doctors, we are able to appreciate crepitation wheezing on a very skilled side. But what happened? We fail to appreciate air entry, because whenever you auscultate the chest, not only trying to hear the added sound like wheezing, crepitation, always check air entry whether on both sides it is equal. It's a very clinical medicine. Okay. Suppose if air entry is, if there is no air entry, only two possibilities. If there is no air entry, two possibilities, either pneumothorax or pleural effusion. You just, if you percuss on that particular area, then if you are able to feel the dullness, then probably you are dealing with pleural effusion. Suppose if you have hyperresonant note, then it may be a pneumothorax. So, what I am trying to say, the most important, the clinical examination during acute chest pain is, while you are auscultating, if you are not able to appreciate the air entry, or if there is no air entry on particular side, probably you can pick up tension pneumothorax at the earliest, or air entry is equal on the both the sides. Clinically, you can exclude tension pneumothorax as the cause of chest pain from the list. That's one important clinical finding among that 6 causes I enumerated. Then by means of clinical examination, you can exclude tension pneumothorax to some extent. And then what would be the next step? Then when you check blood pressure, okay. So, suppose chest pain, acute chest pain with hypotension. So, when will you call it as hypotension? When patient develops systolic blood pressure below 90 is called hypotension, or mean arterial pressure below 65. So, what do you mean by mean arterial pressure? Check patient systolic pressure and diastolic pressure, take 1/3 systolic pressure plus 2/3 diastolic pressure, add both of these parameters. If it is below 65, then the patient is in hypotension or patient is going for shock. Suppose somebody is coming with chest pain and shock, then probably you can comfortably say probably you are dealing with acute coronary syndrome or iotic dissection or tension pneumothorax. Probably pericarditis, they may not have this kind of hypotension, or pneumonia, they may not have this kind of hypotension. So, blood pressure may give rise to clues. In fact, you can narrow down the diagnosis. And another, pneumonia, how will they present? Usually pneumonia patient, the chest pain may not be in a central in origin. They may have in the periphery. So, they will have peripheral chest pain, and even 2 weeks before, one patient came with right side severe chest pain. But this chest pain, pneumonitic chest pain, since it spreads to pleura, when they inspire, because of inspiration, the chest pain will be aggravated. That is a clue for pneumonia followed by pleuritis. So, but it will be in the periphery. But anyway, unlike something like ECG, if you take chest X-ray, 2 more diagnoses you can make it out. One, when you take chest X-ray, tension pneumothorax will be evident. One, and second one, very clearly, if you have pneumonia, they will have some homogeneous opacity in the lung fields. So, chest X-ray in that way it may be helpful, but chest X-ray very clear, very normal in the case of acute coronary syndrome and pulmonary embolism and iotic dissection. Then how will you suspect pulmonary embolism? Generally, pulmonary embolism won't occur in a very normal person. It will occur in a very high risk groups. So, what do you mean by high risk group? Somebody is giving history, sir, the patient has been bedridden for a week, or patient has undergone a hip surgery, following which patient was lying down for a week, or patient has some malignancy or diabetes. So, any situation which makes the patient for prolonged lying position for a couple of days, then probably you can think of pulmonary embolism. So, what is the clinical signs of pulmonary embolism? They will present with sudden onset of dyspnea and hypotension. Because of pulmonary infarction, they may have also peripheral chest pain, not central chest pain. Central chest pain very typical of acute coronary syndrome and aortic dissection. But when patient develops hypotension, then probably you can think of acute coronary syndrome, aortic dissection and pulmonary embolism also you have to think. But when you take ECG, pulmonary embolism may not show any fluoride finding. Commonest finding would be just a sinus tachycardia. One typical finding is that's called S1Q3T3 pattern. Lead 1 you will have S, and lead 3 you have Q, and lead 3 T wave inversion will be there. Even though it is a very specific, only 15 to 20% of patients only exhibit this finding. So, you can't say a patient doesn't have any pulmonary embolism only with the clinical examination and ECG. Then you have to move to next step and echo. So, what is the purpose of echo? If you do echo, if it is an acute coronary syndrome, you can find some hypokinesia because of coronary arteries block. What happened? The particular segment of the heart will be weak, there won't be much contraction, that is called hypokinesia. For example, maybe inferior wall hypokinesia means inferior wall of the heart may not have adequate contraction as compared to rest of the myocardium. Likewise, if you are able to appreciate hypokinesia of the segment, then that clearly signals that you are dealing with acute coronary syndrome. If it is aortic dissection, suppose aortic dissection involves the root of the aorta, that means the aortic valve area, if it is involved, then you will have aortic regurgitation. Any acute chest pain, if they have aortic regurgitation and there is no other hypokinesia suggestive of acute coronary syndrome, then you can think of aortic dissection. So, aortic, if you take echo, then you can find aortic regurgitation in the case of aortic dissection. Then the root of the aorta may be also dilated, that can be also evident in echo. So, echo this amount of helpful, right. And the third one, D-dimer. So, D-dimer is very, very specific for pulmonary embolism among this chest pain. D-dimer may be raised in various conditions like even any trauma or sepsis apart from pulmonary embolism, but in pulmonary embolism D-dimer will be grossly elevated. So, what do you mean by D-dimer? So, normally there is one thing called a dimer that binds the platelet together. Okay. So, what happens when pulmonary embolism occurs, when the clot is formed, because of this dimer all the platelets are aggregated. So, normally when clot is formed, simultaneously lysis also will be started by our protective mechanism. So, once clot wherever it is formed, immediately the clot will be lysed by our body, by our this protective mechanism. When lysis occurs over that clot, what happens? The dimer will be released, that is called D-dimer. So, D-dimer will be grossly elevated for in pulmonary embolism, that is a big clue in pulmonary embolism. So, this is the way by which you can you can be able to differentiate the causes of chest pain. But one thing is very important. If somebody is coming with chest pain, if they have comorbid illness like diabetes, dyslipidemia, hypertension, but you are thinking strongly in favor of acute coronary syndrome, but ECG doesn't show any finding, don't be content with single ECG. Okay. If you think that the patient might have a possibility of chest pain, then better to observe the patient in the hospital couple of hours, where patient can undergo serial ECG, hourly ECG. Sometimes second and third ECG may show STT changes. Likewise, we are doing generally tropi for acute coronary syndrome. Don't be convinced with one single tropi. If you are very confident that you are dealing with acute coronary syndrome, then probably you can go for multiple tropies which may show gradual elevation. So, these are the two things you should not forget when it comes to acute coronary syndrome. So, what would be the treatment basically? If you suspect acute coronary syndrome, you can give cardiac loading dose like aspirin 325 milligram, clopilot 300 milligram, atorvastatin 40 milligrams, sorbitrate 5 milligram, flavidan MR-lite. Why we are giving this clopilot 300 milligram? Sometimes in abroad they are giving 600 milligram. So, when you give more doses, they have found that it is able to immediately inhibit the platelet aggregation. So, it is able to prevent the rupture of that block. So, that is another idea behind the loading dose of cardiac medicine. But if you suspect aortic dissection, like if you keep on taking ECGs, but ECG does not show any signs, tropi not elevated, does not look like acute coronary syndrome, do not wait. Patient better to be referred to aortic dissection, because aortic dissection immediately warrants CT angiography, because CT angiography only will clearly say that whether patient has CT aortogram only clearly shows that the patient has aortic dissection, which may warrant surgical intervention very immediately. Patient to be shifted to the tertiary center very immediately. Pulmonary embolism also, if patient has pulmonary embolism, echo will show right atrium, right ventricle will be dilated. So, when you suspect pulmonary embolism, right atrium, right ventricle is dilated. So, patient should be subjected to CT pulmonary angiography, which is a very definitive investigation. CT pulmonary angiography, if it shows, then there is a thrombus in the pulmonary vessels. This thrombus can be lysed, okay, with the help of altiplase and tenecteplase and so on. So, once echo or D-dimer picks up pulmonary embolism, if you have facilities, you can manage the patient or refer the patient to pulmonary embolism. And pneumonia, of course, the appropriate antibiotic to be instituted. Likewise, pericarditis also, you have to find out the cause for pericarditis. So, based upon that, according to that, you have to treat. I sincerely hope now you are able to invoke some ideas about how to approach acute chest pain. In coming days, let us discuss some more topics. Thank you.